probably I still don't have anything to say, but much of what I'm going to do is try to put the Sepsis Initiative in perspective. And I think that you are here, you've heard a lot of the problems that we will have in initiating the program. This first slide, this is a slide of Vancouver, British Columbia, Stanley Park, North Vancouver, etc. And I hope some of my friends will choose to come visit in there. But please come when I'm not around so I don't have to cater to you. Anyway, what I'm going to talk about as the first part is a lot of what Kath has said about the pitfalls of looking at the initiative, the WHO guidelines, etc. So I won't spend much time. I'll just paraphrase because Mark and Kath has touched on much of this already. The reason why we decided to look at this initiative is that when you look at the top killers of children, as you can see, it's all listed here: pneumonia, diarrheal disease, neonatal sepsis, etc. And apart from perinatal asphyxia, all are infectious causes, and 80% of deaths, so one way or the other, is due to sepsis. The fact is that if you would like to make a difference, I guess this is where the bang for your buck is. Now, Joe later today will be going through cases with the guidelines, so I'm not going to go through the guidelines in any detail. The fact is, what I wanted to point out from the guidelines here is that the early part of it, as Kath had mentioned, can be done in most hospitals, most institutions with healthcare workers, etc., who can recognize the decreased mental status, perfusion, etc., and administer initial treatment. And the fact is that it's time sensitive, as we know, and you heard about the issue of transport, etc., that regardless of the guidelines you have, if you do not have the resources and you do not adhere strictly to them, the outcome is not going to be very good. So this is the guidelines that we have adopted in our emergency department, which really follows the guidelines that Joe and the group has put together. And in fact, this is the 2007 revision, which we're still undertaking right now. The point is that when we look at the PICU area, much of it is not relevant to most of the world. So when we start looking at up to this part, we can say that, yes, there are some patients that we can treat even in a resource-limited environment. But beyond this, when we start to look at refractory shock, ECLS, etc., the fact is that not many places in the world have the resources, and I think many of us in the developed world tend to forget that when we put guidelines together, we think of the practicalities of it, because we think that, gee, we can do it in our environment, why can't others do it? So basically, I think the guideline, what we're trying to do now is to determine, based on this and based on the experience and the work of others who have worked out in the field there, is to put together a pragmatic sort of approach based on resources, based on child mortality, based on the sort of region of the world. So based on those factors, put together a sort of rational approach, and hopefully we can capture some data, we can see where we need to improve things, where we can help, etc. I've always said that the World Federation, to a large extent, was put together in the long run to help our colleagues in developing countries, help children in developing countries, because we all know about the 90-10 split. 90% of the resources are spent on 10% of children in the developed world, whereas 90% of the children who die or who are disadvantaged get 10% of the resources. So those are the thoughts behind it. But as good as thoughts and as altruistic as we think that we would like to do good, most good is not going to be done unless we can get data, as you heard, and unless we can be pragmatic and know the limitations of what we're doing. Now, this is a slide, in fact, a friend of mine, Des Bone, had put together and showed me. If you look at if you take a jaundice eye of the sepsis bundle and guidelines, this is the adult bundle. Early goal-directed therapy is 16% reduction in mortality. Recombinant activated protein C, a 13% reduction. Steroid supplementation, 10%. Tight glucose control, 32%. Low tidal volume, 9%. So at the end of the day, it looks like you'll be a lot healthier being septic in the United States. The fact is, obviously we know it's not the case. So if we'd like to look at put in guidelines that would affect the outcome, obviously the ultimate outcome, we'd like to look at what are the causes or what are the factors that lead to sepsis. And obviously morbidity is due to age, obviously premorbid status. You heard Kat spoke about the malnutrition being a big problem in the developing world. We heard immune suppression, oncology patient in North America, nature and the source of infection, organ failure, management factors, and we heard about the adequacy of resuscitation, antibiotic coverage, etc., genetic polymorphism. So these are the factors that are known to affect outcome. And this is a slide that Trevor has given me. But if you take it in a broader sense, and what Kat was telling us is that there are other factors that influence quality of care and would impact on any initiative that we put together. Physical buildings, that drugs, procurement, supportive therapy, oxygen, IV fluids, etc., human resources, the guidelines that we put, the evidence base, the financing obviously is a big problem even in the developed world. Transport and access, community thing, quality assurance initiatives, etc., and other soft aspects that we as pediatricians think about. So there are a lot of other factors. You've got to put it in a bigger context. And obviously we cannot have blinders in what we're going to do. And you've seen the slide that there have been decreased mortality in pediatric sepsis, and you can see the meningococcus that Mark had spoken about, malaria, and Mark spoke about, and dengue. But the fact is that these successes that we're seeing here has not been uniform, and it has been due to dedicated people in niche areas in the world, and it has never really translated to the broader goals that we'd like. Now, you've seen this one also, the deaths, most of the deaths in Africa and India, as you can see, the distribution of morbidity and mortality. And you've also seen this slide where in Africa you can see the density per 1,000 population of healthcare workers. You can see in America it's 10 times, if my math is correct, 10 times that's what in Africa. So you saw yesterday, if you were at the opening ceremony, when Trevor spoke about the overlapping of the global health workforce. There's a reciprocity between where you don't have the workforce, these are where the children are dying. So those are the type of things that we're up against. And you heard Kath spoke with some of the work of Mike English. This is a summary of 14 hospitals in Kenya. And what I'd like to point out here, if you look at any one of the diseases here, for instance, pneumonia, diarrhea, neonatal sepsis, etc., you can see wide case fatality rate. And obviously when you're seeing the death of, say, 3 to 21% in a diarrheal disease or 2 to 20% in pneumonia, obviously that we still have a lot to do, and we still have a lot to achieve. So these are the sort of limitations that we're faced. This is also from Mike English. When you look at two of the diseases, we're talking about pneumonia, which leads to sepsis, and malaria. The documentation, I guess Kath touched on that to some extent. You can see mental state documented in only 51% of cases, respiratory distress documented even less, pneumonia, similar sort of pattern. So the fact is that if we do not have good documentation, we are not going to be able to achieve treatment. And again, when you look at performance measures within the system, again, proportion at each hospital with documented weight, 35% only, proportion receiving oxygen, etc., 58%. So malnutrition without a specific treatment plan, as you can see, all those are the sort of Achilles heel that would help us. We heard about, it's not unique only in Kenya. This is one from Mark Hatherell in South Africa, and you can see again, at least in 1998, and in fact, from what I heard, not much has changed in many areas. Rural hospitals without oxygen, without resuscitation equipment and protocols, etc. Poor use of IV fluids, inadequate monitoring, poor airway management, etc. In fact, the other thing we heard about a lack of transports. Kath had some very good pictures of it, but many areas there's no transport, as you can see, from primary care, from home to primary care to district hospitals. And there are different reasons for lack of vehicles, inadequate roads, inability to pay, and healthcare vehicles targeted during conflicts, etc. Now, much of this, in fact, we heard about the system. You've got to have the entire system. In fact, this afternoon at 5 o'clock, when I'm talking about a pediatric emergency ICU interface, I took it broader than that and spoke about the entire system of care, because we have seen very, very clearly that even if you have a good transport system and you do not have the inpatient care or upstream or downstream care, you're not going to be making a difference in outcome. Similar sort of thing, you see in transport system, taxis, buses, etc., bicycles, ox carts. So it's not something that we are looking at in abstract. And this is a study that we did in Chennai, India. And this is patients who came in septic shock. Those who were fluid resuscitated and did not require mechanical ventilation, you can see survival is over 90%. It's pretty good. In groups B and C, these are groups that required, well, all three, B, C, and D, required mechanical ventilation. Group B, a ventilator was immediately available. You can see survival is about 75%. C is the same thing, a ventilator was available, but within 6 hours. So these patients had to be bagged manually for almost 6 hours. That's pretty good. But once you go beyond 6 hours without having a ventilator and manual ventilation, the mortality was very high. In fact, half the kids or greater died. And this is one that is very interesting that I also got from Trevor. And you can see exactly what Kath was saying, what Mark had said. The fact is the child comes, unvaccinated child from a remote village, cough, difficulty breathing, brought by the mother to the hospital with a rash, etc. Doctors not available, nurses treated overnight, oxygen cylinder empty, no IV fluids, etc. Arrive at a base hospital moribund in the morning, referred down further down. The ambulance don't have gas or anything else. Obviously, child arrests and dies. And this is what the reality of what we face. Now, that was on the sort of downside, and I'd like to talk a little about the initiative now, what has worked. And in fact, I hope that this would be a new dawn. This is the start of the discussion, and many of you in the room, I hope most of you would participate with us. Many of you will, I hope, with participation, will start asking the appropriate questions as we saw, and then start providing some of the answers, because this is not the end. I think this is the beginning of what we're trying to do. So if we look at some of the things that have worked, and Dr. Bang is going to be here. I'm not sure if he's here as yet, but this is one system that has worked using village healthcare workers in India, in this Gadchiroli in India, where 39 villages, you can see over 5,000 neonates were sort of screened and managed at home for sepsis. And in brief, what he did, there was health education for the families of the danger signs, village healthcare workers monitoring, because obviously many places, you know, we talk in terms of, well, we need a physician assessment, etc. We've heard that's not going to happen in most parts of the world where these kids are. Sepsis was diagnosed, and you can see for sepsis, patients were informed what to do. Parents were informed. They can either go to the hospital or the home treatment with IM gentamicin and cotrimoxazole, daily visits, etc. The bottom line is that if you look in the preterm infants, home-based treatment, there was a 67% reduction in mortality, and low birth weight, 72% reduction. And if you look at the graph, there are several graphs, but in the interest of time, I put this one. The infant mortality rate, you can see in the intervention area, it dropped from about 70 per 1,000 right down, and you can see it was sustained by the continuation of care, whereas the control area, you can see it remained high, okay? So this is one thing that has worked, and the fact is that we can learn from that. How we use this in our initiative is still to be decided. You can see what was treated in his group. There's a large group with sepsis management, 36%, and with unexplained illness, 4%. We're not sure if they were septic also, but the fact is that what he did is relevant to the patients with sepsis. Now, zinc supplementation. So what we're saying, you heard about malnutrition, etc., and I don't think we can only focus downstream to the kids who present to us with sepsis in dire straits. I think that we need to go upstream and talk about the prevention, etc. And as you heard Kath said, we need to be advocates for children. So, and I think that Trevor echoed the same thing yesterday, that we need to be, as a group, advocating better nutrition, better water, housing, etc. for children. Well, this is one thing that we can advocate to zinc supplementation. This is a study from the Lancet. This was in Bangladesh, where simple zinc supplements were given to children, and you can see pneumonia was less, okay, relative risk less, diarrhea was less. Total deaths in the group that got the supplementation were 2 versus 14 in the placebo group, and there were no deaths in the pneumonia group who had gotten the zinc supplementation. So the fact is that simple measures can work. We spoke about a lack of ventilator in many areas. In fact, even during the last few days I've been here, quite a few of my colleagues have come and said the same thing, we don't have ventilation, etc. Well, simple measures can work, and this is the whole intent of it, as Kat said. Simple method of assessment, simple method of treatment will likely work for most children. And this is one study looking at, I think this was from Trevor's group also. We look at oxygen mask given to 19 patients. And for 30 minutes, that was the initial treatment. One case failed, as you can see, and the one that failed went on to nasal CPAP, which improved. There was 18 cases which were successful with oxygen masks and high flow oxygen only. But after the 30-minute trial, 12 worsened. They all got nasal CPAP and improved. And those in the nasal CPAP group, most improved. And in fact, only 4 cases of the entire population had to go on ventilators. So I think that we have, as I said, some indication there are things that we can use. There are things that we can use in resource-limited environments that may work. This is Kath's work that you heard about already. I won't spend much time on it, but the fact is her work on malaria resuscitation, showing that there was no difference in the primary outcome, which was resolution of metabolic acidosis, but mortality in the albumin group was only 4%, whereas in the saline, the control group, it was 18%. And this shows it very dramatic graphically in the albumin group. Mortality is very low in the lactated ringer group. It is higher. So another work from Bridget Wills, again, looking at dengue, comparison of 3 fluids. Again, Ringer's lactate was effective during the initial resuscitation of shock as compared to the colloids, which is good news for many places where obviously cost is a factor. And again, this shows that graphically, dextran, starch, and Ringer's lactate, there was no difference in outcomes. Now, we've heard about the dengue shock success story with the 100% survival regardless of fluid use. So what I'm saying is that there are areas, niche areas, where people who are dedicated and who are working in the area have been able to make a difference. The magic is how we translate that to larger populations. We know from the group in Pittsburgh with Joe's group, if we use the Pals apples sort of treatment, in other words, we look at early time-directed, goal-directed treatment again. You can see with apples and Pals use, we have been able to decrease the shock index, okay, here. Whereas when no Pals are used, there is no difference in shock index before and after. And the fact is very dramatic odds ratio of survival if shock, reversal of shock and survival with the resuscitation consistent with the ACCM PALS guidelines. The fact is that this happened because there was a system in place. There was a system, communication with the community hospitals. The reversal was done in the community, a good transport team, etc., to bring the few patients, the ones who really needed care, rapidly to the referral center. And again, in fact, the theme have always been for me, having trained both in emergent ICU and looking at the entire spectrum of the system of care. Any weak link in the chain is going to be doing the kid a disservice. But this is a part of the good news when you have a system in place. We also know that early antibiotics need to be given, and the old guidelines did not stress early antibiotic coverage. This is work from Anand Kumar from Winnipeg in Canada. This is in adults, actually, but it shows that for every hour that you delay antibiotic treatment from the time of hypotension, there's an exponential rise in mortality. So the new guidelines will stress the early antibiotic treatment. This is some work from the meningococcal group. Mark Peters has spoken about this. Delay inotrope administration resulted in 22.6-fold increase in mortality. You heard some of the work, the Oliveira work in Latin America, and Mark, in fact, went through this in greater detail to show that, looking at goal-directed therapy with saturation, etc., does make a difference, but obviously in a smaller group of patients. So if you're looking at the guidelines, this is looking at way downstream again. Other things downstream, CRRT improved outcome when used before 10% fluid overload. By one group, you heard about multisystem failure and thrombocytopenia. Plasmapheresis has made a difference in those, and you've also heard about the study that we did in Chennai, where diuretics and peritoneal dialysis were effective after the initial resuscitation. But these are downstream, and I'm saying that where we're going to make the big difference is early on. And ECMO, very few centers, obviously, the resource-rich countries can talk about ECMO and as that. But ECMO survival has increased in refractory septic shock, and in those areas in which there are resources, obviously it's reasonable treatment, and hence that's the reason why it is part of the entire algorithm. You heard Kat talk about the IMCI management of childhood illnesses. Again, the fact is that I think it has been very successful. It has had broad scope, etc. But again, when we come to sepsis, you can see that the dilemma that, as Kath mentioned, with the physician's face with a child who comes in now in shock. The fact is, where do they fit within the guidelines? And this is where I think that we can make a difference, and where we can sort of start putting together data that can help really change the guidelines, etc. In fact, I've spoken to Trevor about that a while ago, and obviously we need the studies, we need the input from many of you in the audience. Finally, I'd like to end with the last few slides, and what we intend to do, we'll be, on the last day, we'll be talking more about the Sepsis Initiative, and I'll have this live, basically what we are trying to do, and basically what we are trying to do is, I think initially it's really getting people to subscribe to this stock taking, seeing what is happening in various parts of the world, and then sort of start to realize where we can tweak things, where we can help, etc. And there'll be different bundles, as you can see here, for non-industrialized setting with child mortality rate greater than 30, then less than 30, industrialized, developing, and industrialized, developed nation. So I won't spend much time on this now, but what it would be, we hope to have it web-based, where people can go on the web and sort of enter data. There'll be an administrative bundle. There's going to be a clinical practice parameter based on simple things and based on escalation of therapy as resources become more available. And I realize that not everyone will have access to the net, not everyone will be able to enter the data or participate initially, but I think that once we start, we hope that we'll be able to get resources and assist in this. And the whole idea also is to have a good way of tracking what is really happening, and then hopefully we can start asking and answering some of the same questions that Kath has already outlined. So this is just the way it would look. I gave another example of the administrative bundle for the less than 30, and this is what it would look like. What I would encourage you is to go on the website if you haven't and look and see what we have so far there. There will be a lot more put on the website. In fact, the guidelines will be placed on the website. There will be the issue of the bundles, etc. And right now we're taping many of these lectures that will also be there. So hopefully that we can start working on it, helping our colleagues. But I hope that we can have vigorous discussion over the next few days, and I hope that on the final day, most of you will be here such that you can participate again, see what we're trying to achieve live, because the intent of the final day really is also, after having heard everything, is to come, with questions, have a lively debate, and hopefully we can take it from there. Thanks very much for your time.